Welcome and thank you for joining our Men's Health webinar. I'm your host, Margaret. We'll start with a few housekeeping items and then I'll introduce tonight's speaker. First, your participation in tonight's webinar is completely anonymous to the other attendees. No one can see your face, your name, or hear you. If you wish to ask a question, please type it at the lower part of your screen and we'll address these questions at the end of the presentation. Any comments or questions entered into the chat box can only be seen by myself and our speaker. Our presentation tonight will last for approximately 1 hour and be presented by Dr. Michael Granieri. He completed his undergraduate and medical education at Northwestern University, graduating with distinction. He served his surgical intern and urology residency at Duke University. And then Dr. Granieri completed a 1-year fellowship in male reproductive health and reconstructive surgery at the New York University Langone Medical Center. Dr. Granieri treats a broad range of urological conditions, including erectile dysfunction and male urinary incontinence. Thank you for joining us tonight. I'll turn it over to you, Dr. Granieri, to get us started.
Thank you, Margaret. Yeah, I'm very excited to be here, and I just want to say thank you to everybody for participating tonight. And let's just dive right into it and start talking about men's health. Okay, the title of this presentation tonight is The Signs, Symptoms, and Treatment Options for Erectile Dysfunction and Male Stress Urinary Incontinence. So this is myself, Dr. Michael Granieri. I work at the Conrad Pearson Clinic. Here's my contact information, phone number, and our website. And let's start learning about erectile dysfunction. So erectile dysfunction is defined as the inability to achieve or maintain an erection that's firm enough to perform sexual intercourse. And it is actually a very common phenomenon in the United States. Roughly about 1 in 5 men, so about 20% of men aged 20 or older will suffer from some form of erectile dysfunction. So it can affect men very young. But as we get older, we'll notice that it becomes much more prevalent or common. About half of men, so 50% of men by age, or at least over the age of 40, will have some form of erectile dysfunction. I mean, that is extremely common. So let's just talk about the natural process of an erection. So when somebody's aroused, the nerves around the penis, they become activated. And what this does is it signals to some of the muscles in the erectile tissue to relax and allows for more blood flow into the penis. And the penis becomes engorged with blood, okay, and it allows the penis to stiffen. And with this, the veins in the erectile tissue become constricted, so blood can't leave the penis, and that's what enables the penis to ultimately remain erect. Now, a lot of times people ask, well, why do men develop erectile dysfunction? It can be a tricky question. There's not always a single reason why. Many times it's multifactorial, and there can also be physical causes and sometimes psychological causes as to why somebody would develop erectile dysfunction. Some of the physical causes per se would be, age. So as we get older, erectile dysfunction becomes more prevalent. Any history or current smoking, diabetes, high blood pressure, high cholesterol, depression, obesity, and in general, just a sedentary lifestyle. And in my practice, I'll see that, a lot of times men will have not just one of these, but sometimes a combination of these. And as you can see on this pie chart here on the right, overwhelming majority is some type of vascular cause where the blood vessels in the erectile tissue just become narrowed, or there's a component of diabetes as well. So now we do know that although erectile dysfunction is a lot of times a physical problem, it can also have psychological effects as well. A lot of men who experience erectile dysfunction, they can experience anxiety or depression or low self-esteem or low self-confidence, and oftentimes a decrease in the quality of their life. And a lot of times what we'll see is that men with erectile dysfunction tend to withdraw emotionally and physically from their partners. Oftentimes, what we'll see is that, one of the most enjoyable aspects of a relationship, sexual intercourse, and can sometimes be one of the aspects that's most frustrating. And a lot of times, either the man or partner will withdraw or try and avoid from sexual activity just because it can sometimes be a source of frustration. And this is not an uncommon thing that we see. And that's one of the reasons why I feel like restoring or treating erectile dysfunction can be helpful in so many different ways. So let's focus on the relationship between erectile dysfunction and diabetes. So half of men with diabetes will have some sexual dysfunction caused by their diabetes. And unfortunately, we do know that patients with diabetes and erectile dysfunction oftentimes may be less responsive to treatments such as Viagra and Cialis, those oral pills that help with erections. And sometimes what can happen is that erectile dysfunction may be one of the earlier initial presenting symptoms of diabetes as well. Now, why is that? Well, the reasons why erectile dysfunction can emerge in somebody with a history of diabetes is that as men age, the diabetes can make it worse, and the blood vessels and the nerves can be damaged by, high blood sugars or poorly controlled blood sugars. A lot of the pills that we use to treat erectile dysfunction, Viagra, Cialis, they do require stimulation, i.e. the nerves, and healthy blood vessels. But a lot of times, diabetes can affect both the nerves and the blood vessels, thus making pills less effective. Now, there are some factors that we know may increase erectile dysfunction in men with diabetes. Advancing age, how long they've had diabetes for, i.e. like how many years, what their overall blood sugar or glycemic control has been. A lot of times an A1C can be reflective of this. And it's always important to get a sense of, has somebody been optimally controlled for a while, or if they had periods where they've been very poorly controlled. And a lot of times we can see that can have a big effect on their erections. If they also have coexisting vascular disease or heart disease as well. So let's talk about erectile dysfunction and heart disease. It's another medical condition that can also be intertwined with erectile dysfunction. So the link between erectile dysfunction and heart disease, there's this old adage in urology that the penis is the window to the heart. And what this really means is that a lot of times erectile dysfunction can be one of the early symptoms of heart disease and can precede heart disease by almost 2 to 3 years, meaning somebody may develop erectile dysfunction 2 to 3 years before they start having any signs or symptoms of heart disease. We do know the severity of your erectile dysfunction can be related to the severity of your heart disease. And if you see on this bottom point here that erectile dysfunction precedes coronary artery disease in almost 70% of cases and could be considered as a warning sign for heart disease. I think that's why it's important, for men and also for, providers to know that, when a man starts presenting with signs of erectile dysfunction, it's very important for them to also, get an overall, physical exam assessment of their cardiovascular health as well. I think that's very important. So let's talk about erectile dysfunction before heart disease. So we do know that heart disease and erectile dysfunction can be related. In fact, heart disease and ED are considered two signs of the same disease process. And really what this boils down to is that it's more or less physics. The diameter of the penile arteries are very narrow and they're much more delicate than a lot of the other bigger blood vessels in the body, the ones supplying the heart or the carotid artery or the femoral artery. And so a lot of times you start having any plaque buildup in the penile artery, you notice that you're not going to get good blood flow there. And one of the side effects is that you may not get good erections. And so you can see a demonstration of that on the bottom. So what are ways that we can reduce our risk of heart disease and in turn erectile dysfunction? Well, improving heart health through a healthy lifestyle may lower your risk or progression of erectile dysfunction. So eating well, exercise, physical activity, losing weight, stopping smoking, limiting or avoiding alcohol, and then also taking steps to reduce stress. And it's just important, to involve your primary care doctor, your cardiologist, just for regular checkups and medical screening tests. Okay, so let's talk about another medical condition that can oftentimes be associated with erectile dysfunction. That is low testosterone. So low testosterone occurs when the men's body produces less testosterone than normal. Okay, it's more likely to happen in men who are older, obese, may have diabetes or poorly managed diabetes, sleep apnea, or chronic medical conditions that affect both the kidneys, the liver, or sometimes HIV or AIDS. Now, there's a lot of different symptoms that one can have if you have low testosterone. They may include, but they're not limited to, the following: reduced sex drive or low libido, sometimes decrease in the strength of your erections or just trouble getting erections. You may notice decrease, pubic hair, armpit hair, shrink, the size of the testicles may decrease, hot flashes affecting your sperm parameters, depression, difficulty with concentration, increased body fat, decrease in muscle mass, decrease in energy level or endurance. Now, the good news is there's a lot of great treatment options for low testosterone. They can include testosterone injections, either kind of gels or patches. There's new oral options available, and there's also some nasal gels as well. And there's some other options as well we could talk about if needed in the Q&A session. Okay, so the next topic we'll talk about is erectile dysfunction and its relationship to prostate cancer treatments. So a lot of times when a man gets treatment for prostate cancer, such as a surgery, there's a concept of a nerve sparing procedure. And what this is designed to do is help preserve the nerves that help control our erections. But sometimes during the procedure, it may not be indicated to preserve those nerves, or you could have a temporary issue where the nerves don't work as well as they did before surgery. And this can affect a man's ability to achieve an erection on a temporary or permanent basis. And if it becomes more of a permanent option, there are a lot of different treatment options to help. So this is kind of a schematic or a cartoon. In the first picture here, you can see the prostate in that blue circle. And more or less what happens during a prostate or prostatectomy or prostate removal is you remove the prostate and then reconnect the urethra. A lot of times the nerves that innervate or control the process of erections go right alongside the prostate, and sometimes they can be affected during the prostatectomy and in turn affect your erections. So we do know that, unfortunately, this is common after prostate cancer treatments. About 25 to 75% of men who've had a nerve-sparing prostatectomy may have some form of erectile dysfunction afterwards. And even with the most advanced treatments we have, robotic nerve-sparing procedures, ED may persist a year or more after surgery. That's why I find it's very important to make sure that you talk to your urologist, and if there's a specialist that can help with erections, to talk to that specialist as well. Okay, another disease process that can lead to erectile dysfunction or trouble with erections is called Peyronie's disease, and that's essentially its curvature of the penis. So what Peyronie's disease is it's more or less a disease process where scar tissue will build up or plaque will build up on the erectile tissue or the covering of the erectile tissue in the penis. And when this happens, they can ultimately, not always, but many times lead to a curved or a bent penis, especially or most notably during an erection. Now, Peyronie's disease is a benign process. It's not something that's cancerous. It's just scar tissue or plaque that's built up in some of the erectile tissue or the covering of the erectile tissue. And it's something that can, with the curvature itself, prevent the ability to engage in sexual intercourse and in turn cause erectile dysfunction. So treating it often becomes very helpful when you're trying to help restore a man's quality of life and treat their erectile dysfunction that's from Peyronie's disease. So the good news is there's a lot of great treatment options. Sometimes, in this active phase of Peyronie's, when it's first starting and there's pain and inflammation, you can give some pills that can help with the inflammatory process. There could be also injections that can help break up the plaque. In addition, there's other surgical options that can either help remove the plaque or help straighten the penis. And then there's a consideration for a penile implant as well for men who have both trouble getting a rigid erection and who also have curvature of their erections that interferes with the ability to have intercourse. So one of the things we'll talk about is, what really should men know about erectile dysfunction and Peyronie's, and how does a penile implant help both of those? So in somebody who has, poor erections and also curvature as well, a penile implant may be a great option for that patient. The reason is the, penile implant is there to help address the erectile dysfunction, but with regular cycling of the device over a period of time, usually months, they can also help correct that curvature to a point where hopefully, a man is able to engage in, intercourse without the curvature interfering with intercourse. And I think in a situation like this, it's really important to talk to a specialist who is very comfortable managing both Peyronie's disease and erectile dysfunction. Okay, so let's talk more about some of the old tried and true treatment options for erectile dysfunction. A lot of these you may have already heard of. So we have oral medication or pills, a vacuum erection device, sometimes called a pump. Then there's penile injection therapy, and lastly, penile implants. And we'll talk about each of these in detail. So one of the first things we can always talk about to help with erections is lifestyle changes. In my view, a lot of times a healthy lifestyle can very much help a lot of different medical problems that a patient may have. But in terms of erections, it can help prevent future progression of erections. And some of these options, we talk to patients about is, you're smoking, to quit smoking, engage in exercise, healthy diet to help lose weight. In addition, some men may have some type of stress-related or psychogenic erectile dysfunction. Sometimes therapy with a sexual therapist can help that aspect of erectile dysfunction as well. All right, so let's talk about oral medications, or we call them PDE5 inhibitors, but you probably know them as Viagra and Cialis. Now, we do know that there are a number of prescription medications available. And typically my view is that when taken properly, and with the equivalent dose, that they can all achieve about the same effect. They just have some slight variation in how quickly they work and how long they could last for. We do know that a lot of times they have similar side effects, such as headache and flushing, sometimes upset stomach. And I think the biggest thing I always tell patients is, you cannot take this if you take nitrates for chest pain, so it's contraindicated. And you should always be mindful if you're taking any alpha blocker therapies as well. And it's important to talk to a urologist about if you are taking those types of medications. The next treatment option is a vacuum erection device. So the way this really works is you have more or less a hollow plastic tube that goes over the penis, and this more or less creates a vacuum, meaning negative pressure to help draw blood into the penis. And once that happens, then there's a kind of an elastic tension ring that goes on the base of the penis. And this helps kind of simulate what we had talked about at the beginning of this presentation, where you want to try and draw blood into the penis and then trap it there. And so this can be effective, but there are some side effects: blocked ejaculation, bruising, discomfort, pain, penile numbness, and bruising. And a lot of times people will stop this because, number one, it may not work as well as they're hoping for. And sometimes they find it's either cumbersome to use or that it has a little bit of pain or discomfort when they're trying to use it. Next option is intracavernosus injection therapy, or ICI, or penile injections. So this, in my mind, is the strongest non-surgical option. Okay, a needle is used to inject concentrated medication directly into the erectile tissue, and this hopefully will allow for an erection to occur. It's typically done about 5 to 10 minutes before somebody wants an erection. There are some side effects, penile pain. Sometimes you can get a prolonged erection called a priapism. That's typically when an erection lasts longer than 4 hours. And if that happens, you need to go seek immediate medical attention because that becomes an emergency. Long term, you may notice that patients can get scar tissue from this. And then a lot of times, the reasons people will stop using this is because sometimes it just doesn't work. They may not respond well to it, or maybe they have, but over time they may lose the response to it. A lot of times it can be inconvenient. And in my experience, what patients will typically tell me is that, doc, like, my wife and I were ready to have intercourse. And when we're in the mood, I have to get out of bed, go across the house, go get the medication out of the freezer, and then go to my medicine cabinet, get the needles, get the alcohol swabs, and that whole process, then I have to inject and then hold pressure there and then wait for my erection to happen. And the whole process from when they decided they want to have intercourse or have an erection to when they actually get their erection can be 20 to 30 minutes. And sometimes the thrill can be gone. And, so I find that can sometimes be a frustrating aspect for not only the patient, but also their partner as well. And the last option we'll talk about is a penile implant. And so what this really is, it's a device that's implanted into the penis, all right, that's intended to allow a man to have an erection. And what I'll tell patients is it allows you to get an erection. You can make as hard as you want, whenever you want, keep up for as much time as you want. And then when you're done, you press a button, it goes down. So you're back in full control of your erections. It's very nice because the device is entirely contained within the body. It's concealed. So nobody can see it. And once again, it's controlled by the user to achieve an erection. And what it does is it helps allow for spontaneity. And as I said before, it allows for the erection to be sustained for as long as the patient wants. There are some side effects or complications that can happen with the surgery. So postoperative pain, rare risk of infection. We're looking at about 1 to 2% in somebody without, let's say, diabetes, and maybe 2 to 3% in somebody with diabetes. Sometimes you can have a mechanical malfunction of the device or a failure of the device, and very rarely an erosion as well. But if you look at the bottom of the screen, what you'll see is that patients are very, very, very happy with this device. So in a survey of 80 patients who had the AMS 700 penile implant, 97%, okay, almost 100, but 97% would recommend a penile implant to a friend. And Boston Scientific has 3 different types of implants. So they have the AMS 700, which is a 3-piece inflatable penile prosthesis. And it has the MS, or the momentary squeeze pump, and it comes in 3 different variations. And now it also has the AMS 700 inflatable penile prosthesis. So a lot of this is the exact same, except it has the new Tenaccio pump, which can allow for a little easier tactile sensation, easier ability to pump the device, and more efficiency with each pump. And then on the far right, you'll see that there's also a malleable penile prosthesis called the Tactra. And this is not inflatable, so it kind of stays semi-rigid at all times. And it can be helpful in a variety of scenarios. One of them is for patients who don't really have the ability to squeeze a pump well. And that can be for a variety of reasons, but sometimes, a patient with really bad arthritis in their hands, or Parkinson's, who they don't have the appropriate hand dexterity to utilize or squeeze a pump. So let's talk more about the AMS 700 inflatable penile implants. So it has 3 design options, and that's the most variations of any penile implant on the US market. And all of them are available with inhibizone. Now that's inhibizone is a coating. It's a proprietary coating of 2 antibiotics that is impregnated into the device, meaning it's kind of built into the device. And the way it really can help patients is that It's clinically proven to reduce revision surgery due to an infection. And that I really think has been a game changer in the inflatable penile prosthesis. And the AMS 700 in general is it's designed to very closely mimic a natural erection. It provides rigidity when it's inflated, and then it provides a flaccid appearance when it's deflated. Now, I don't know if you knew this, but penile implants have been in use for over 50 years with over 500,000 Boston Scientific penile implants sold. So it's been a tried and true effective option for erectile dysfunction. Now, here are the numbers that really back that up when we talk about patient satisfaction. So, kind of look on the in the navy blue box on the bottom left. Survey of 194 patients who had the AMS 700 penile implant. 95% of patients reported satisfaction with sexual intercourse. 95% of patients were very satisfied or satisfied with their sexual activity. And in a survey of 80 patients, 97% would recommend the penile implant to a friend. Now let's look at a video of exactly how the inflatable penile implant works. Okay, so imagine you're at home and you're aroused or in the mood and you want an erection. Okay, so what will happen is you'll squeeze this pump inside the scrotum. Fluid will go from the reservoir into the cylinders, allowing you to achieve a rigid erection, and it'll stay like that until you're done using the erection. And when you are done, you press this little button on the same pump, and the erection will become deflated and take the fluid in the cylinders and transfer it back to this reservoir. Very simple to use. So let's talk more about, what to expect from a penile implant procedure. So it's typically done on an outpatient basis. I pretty much do all mine as an outpatient. Now there's, a couple of different ways to do the implant. There can be incision made on the penis itself and the scrotum or right above the penis near the pubic bone. Now, many times, all you really need is one incision, and you can achieve inserting the implant in all the components through one incision. The procedure is performed under anesthesia, typically general anesthesia. It usually takes a couple days to return to light activity. And then typically, at least my protocol as well, is I usually wait about 4 to 6 weeks before we start teaching the patient or the man how to start pumping up their device. Usually the scrotum's still a little too sore or tender for the first several weeks after the implant. So usually it takes about 4 to 6 weeks before it's appropriate enough from a recovery and inflammation standpoint to allow for easy pumping of the device without too much discomfort. Okay, other considerations for the penile implant surgery is cost and coverage. So commercial insurers, they may cover the diagnosis and the treatment for ED. Oftentimes, I find that commercial insurers do cover the penile implant, but once again, it'll always depend on the specific details of your insurance and your insurance plan. Now, Medicare, very conveniently, has a national policy which includes penile implants, although coverage may depend on where you live. And I think at the end of the day, if you're deciding this is the right option for you and you've talked to a specialist and you guys both make the decision that, yeah, the penile implant is the right decision, it's really important to talk to your urologist and have them work with you and your insurance to make sure and see if this can get covered. It's not always covered, but a lot of times there's a lot of things you can work with your doctor on to see if this can be covered. And as stated in the bottom, that there may be financial assistance programs available to help cover any out-of-pocket expenses. If you have any questions or want a great resource at the bottom, you can see that there's www.edcure.com/insurance coverage. And that is a great resource should you need it. Now, we'll just talk about some of the intended benefits of an AMS 700 Boston Scientific penile implant. So we know that it's proven, all right? We know that it has very high success rates. 97% of patients would recommend it to a friend. 95% of patients reported satisfaction with intercourse. And it's the only implant on the market that offers impregnated antibiotics into the product that's designed to reduce the risk of infection. It is affordable and is typically covered by insurance and or Medicare. But once again, make sure you talk about the specifics with your insurance company and your urologist. Um, it's also very reliable and durable. It's the only penile implant on the market with Parylene, which is proven in published studies to mitigate any cylinder issues and also increase long-term durability. And this is really designed to be a long-term treatment option for erectile dysfunction. I'll usually counsel patients that, you know, oftentimes this can last 10 to 15 years, sometimes longer. I mean, it's a great, durable, long-term, reliable solution. And the last thing I want to mention too is it's oftentimes can be um, feel very natural, right? It's entirely contained inside the body. It's concealed. No one can know that you have the implant unless you tell them. It's designed to feel natural during intercourse, and it typically does not interfere with the process of ejaculation or orgasm, and it can be spontaneous. You can get erection, you know, wherever you want, whenever you want, and can keep it up for as much time as you want. And as I said before, you can get back in full control of your erections. So there are some risks to the procedure, um, and not all patients are good candidates for the penile implant. That's why it's really helpful to see a specialist, talk about, and see if it's the right option for you. But here are some general risks of the procedure, and they include, but they're not limited to. Um, so it'll make any natural or spontaneous erections or any other interventions impossible. Meaning, what I tell patients is you're essentially committing to a penile implant is the only source of erections for the rest of your life. And if for some reason you had the penile implant removed or it didn't work, no other option is going to work. So you're essentially committing to the penile implant as the only source of erections for the rest of your life. There could be a device malfunction or failure that could require revision. I'll oftentimes tell patients that, this is like buying a reliable car, like a Toyota Camry. It should be something that should last you 15 years. But anytime you drive it off the lot, it's unlikely you're going to have an issue shortly thereafter. But anytime you drive a car off the lot, you could have an issue. And a similar thing can happen with an implant. Once again, it's unlikely to have an issue early on, and it should last you 15 years. But it's just it's a risk that even though it's rare, we have to assume. Rarely there can be an issue with device migration that could potentially lead to exposure through the tissue called an erosion. And then the risk of infection, as I said before, typically 1 to 2%. Sometimes in higher risk patients with diabetes, maybe 2 to 3%. If the device does get infected, typically you have to take the device out. And oftentimes you can either put a placeholder device in, such as a malleable implant, or replace it at a later date. And sometimes you can have pain or soreness or sometimes unintended inflation of the device, although that's been really minimized with new technologies such as a lockout valve. One of the important things to know is that with erectile dysfunction, you're not alone. And there's a variety of treatment options. So it's important, to go and talk to, a physician. It can be your primary care doctor or urologist, somebody you're comfortable talking to kind of go over what your options are and what we can do to help restore your erections. There's also great resources online at edcure.com. Okay, and here's some more resources. Here's a QR code if you want to take a short quiz to assess your symptoms and how they may be affecting your quality of life. Some other resources for edcure.com as well. Okay. So, all right, let's switch gears here. And we're going to start talking about male stress urinary incontinence, called SUI. And what this is, male stress incontinence is when you have involuntary leakage of urine, typically associated with stress maneuvers like coughing, sneezing, lifting something heavy, anything that'll kind of activate your stomach muscles can sometimes cause unintended or involuntary leakage of urine. Now, we know it's very common worldwide. About 13 million men worldwide will suffer from stress urinary incontinence. And in the United States, annually, about 17,000 new men will develop bothersome stress urinary incontinence. So, very common. Now, once again, let's talk about the normal process of urination. All right, the bladder, one of its jobs is to store urine, and urine ultimately will go from the bladder and exit via the urethra. Now, there's you can see here that surrounds the urethra, and the sphincter muscle is contracted, at rest. All right, it kind of seems counterintuitive, but when you don't want to, when you want to keep urine in, this muscle's when you want to keep urine inside your bladder, this muscle is always contracting at baseline. However, when you say, "Hey, I want to go to the bathroom," the first thing your body has to do is relax this muscle to help allow urine to get out. Now, there are some causes and comorbidities that can be associated with male stress urinary incontinence. The most common cause of male stress urinary incontinence is a history of a prostatectomy or some type of treatment for prostate cancer. I see this most commonly with prostatectomy, but it can happen with radiation or some other therapies as well. And the way it can cause this is it sometimes can affect the ability of the external sphincter muscle, the one we were just talking about, to work effectively. There are other causes. Sometimes men who've had treatments for BPH or benign prostatic hyperplasia, sometimes that can lead to stress urinary incontinence. There can be some neurogenic conditions, a history of pelvic surgery, radical prostatectomy, or some other urethral surgeries as well. And any history of trauma as well, pelvic trauma. Now, stress urinary incontinence, may affect your quality of life. And I see this a lot in my practice where a lot of times it can be a big effect on a man's quality of life. One study has shown that men suffering with stress urinary incontinence had higher chances of depression than those without. And the odds of depression increase with the severity of urinary incontinence. And once again, in my practice, I treat male stress urinary incontinence a lot. And I'll see that a lot of times, men will often report that this really affects my quality of life, and it really, really, really bothers me. So we'll kind of talk again about how male stress incontinence relates to prostate cancer treatments. So as we showed in the previous talk on erectile dysfunction, during a prostatectomy, the prostate will be removed and the urethra will be reattached to the bladder. And during that process, a lot of times the sphincter muscle will be compromised and won't work as well. Now, the good news is there's a lot of great treatment options for male stress incontinence. They range from behavioral changes. Sometimes people will say, well, I'm just going to drink less. I don't want to fill my bladder up with urine because I don't want more urine to leak out. So I'll drink less fluids, or I'll take planned restroom breaks where, maybe I'll do some time voiding where I'm going to go to the bathroom every hour, whether I need to or not. And that can help minimize the number of pads. I find that sometimes that can be a temporary fix, but a lot of times it's not a great long-term durable fix, or patients don't find it to be. So a lot of times early on, we'll recommend pelvic floor physical therapy, Kegel exercises, and that can help restore the pelvic floor and hopefully help restore urinary continence, especially in a post-prostatectomy male patient. If they're still having incontinence, there's pads, diapers, sometimes external catheters or penile clamps as well that can help. Now, if the stress urinary incontinence persists for more than a year, typically we'll start talking about surgical options if it's bothersome to a patient. Because at that point, we know that likely you're going to be less likely to see significant improvement than you would for the first 12 months after a prostatectomy or some treatment for prostate cancer. One of those options that can help is a male sling. And there's this great option called an Advanced XP male sling. And really what it's intended for is somebody with mild to moderate stress incontinence. And in my mind, that's about, somewhere between 1 to 3 pads a day. Now, this is a very minimally invasive procedure. It's usually 1 incision, 2 small needle pokes. And the beauty of it is that it works on its own to restore continence. So once it's in, it's hands off. You don't really have to do too much. It starts working on its own. And studies have shown that can be very effective. you can have reduction in the number of pads by 77%. And let's talk about how it works and what it looks like. So as you can see here, the sling is a small piece of mesh that goes around the urethra, and it kind of acts like a hammock to help reposition and support the urethra back to where it was before it had, typically before the prostate was removed. That really what this does is it helps restore normal bladder control. Now, if you look at the bottom here, 88% of 79 patients surveyed recommended the Advance XP male sling procedure to a friend. So as we can see, it's very high success rates. Another great surgical option, typically considered the gold standard for male stress urinary incontinence from a surgical standpoint, is the AMS 800 artificial urinary sphincter. And what this is, it's a treatment option that's designed to treat male stress urinary incontinence following prostate surgery. And it's designed to treat all levels of stress incontinence. We're talking one pad a day up to, I've helped somebody with 14 diapers a day. Soaking diapers. So, and, get people down to being pad free on all levels. It's really a fantastic option, and it's very versatile from that end. And it's also very discreet. I tell patients, nobody can really tell that you have it. And really, it only adds one step to the process of urination. So before you had stress incontinence, you go to the bathroom, and it'd be something you just wouldn't even really think about doing, right? You feel the urge to go to the bathroom, drop your drawers, you go pee, and then when you're done, you just, pull your pants up, and then walk away. With the artificial urinary sphincter, all it adds is one extra step where all you have to really do is, once you feel like you have to urge to go to the bathroom, you go to the bathroom, drop your drawers, but then you squeeze this pump just one time, and then you pee as you normally would. And then once you're done, you just pull up your pants, and then you can walk away. And it's really one simple extra step. And I think there's a lot of, I think that's what patients really like about this, is that it very closely mimics the natural process of urination that a lot of times patients were used to before they started suffering from stress incontinence. And once again, it's fully operated by the patient, so you're in full control of the process of urination again. And it's really important to know that for somebody to be a good candidate for the artificial urinary sphincter, it does require good cognitive ability. Okay, so you need to know, hey, I got to use the bathroom, and also good manual dexterity that, yeah, I know I need to use the bathroom, and I have the ability to press a pump once. So let's talk about how it works more. So it's essentially what it is. It's filled with fluid, and it uses the fluid to open and close a cuff surrounding the urethra. So you can see on this picture, this cuff more or less acts like a belt. It goes around the urethra, and it keeps it shut when you don't want to go to the bathroom. And then when you need to urinate, you press this pump that's concealed in the scrotum once, and the cuff will open, and the fluid will go into the pressure regulating balloon. And then ultimately, the cuff will automatically refill within usually about 2 minutes. And then once it's refilled, the cuff squeezes the urethra shut, and you get your continence restored again. And we'll see a cartoon in a second to kind of give more of an animation of how this looks. So here's a video or an animation of exactly how the AMS 800 artificial urinary sphincter works. So let's just say, hey, I've got to go to the bathroom. All right, you're going to go to the bathroom, and then when you need to go, all you're going to do is you're going to press this pump once. Okay, the cuff's going to open, and you're going to see urine exiting the urethra, and you pee like you normally would. And then once you're, you get all the urine out, and then within 2 minutes, this cuff will automatically close back on its own. And it's fantastic. So let's just talk about what to expect from the procedure. So it's an outpatient procedure. Typically, there's 2 small incisions. They're very small, about 2 to 4 centimeters each. And after a few days, you can return to non-strenuous activities. And usually we wait about 4 to 6 weeks before we activate the artificial urinary sphincter and teach patients how to use it. The reason is a lot of times you want the urethra and everything to heal afterwards. And oftentimes too, just like with the penile implant, you still might have some little bit of tenderness where the pump is. And it may take about 4 to 6 weeks for that tenderness to go away to allow you to use the pump without any difficulty. Okay, so let's talk about patient satisfaction with the AMS 800 artificial urinary sphincter, or the AUS. So if in this navy blue box, you'll see that about 90% of survey patients reported long-term satisfaction. 90+% of patients would get the AMS 800 AUS again. And I can tell you, patients who've had the device and they've had it for a while, and let's just say there's an issue where after 10, 15 years, it needs to be revised. I mean, they're calling right away saying, hey, how quickly can I get this device put in? Because they've seen firsthand how much this can really help their quality of life. And about 94% of patients would recommend the AMS 800 AUS to friends or family. And then you can see on the light blue area that long-term studies that show that most patients will be using one pad or no pad a day after receiving the AUS. 85% after 4 years, 96% after 6 years, and 90% of 435 primary AUS patients at 5 years. Okay, so long-term SUI treatment, cost and coverage. In general, I find that oftentimes the XP male sling and the AMS 800 or the AUS, they're covered by Medicare and most private insurances. I've had very rare issues where these haven't been covered, if I can remember any at all. But once again, in general, coverage varies. So make sure to talk to your insurance company or work with your urologist to see if this can be covered for you. And once again, in the bottom, there's no guarantee of insurance coverage for any procedure or product. So the intended benefits of SUI treatments, really it's to help restore bladder control and being able to urinate when you want to without having unintended or involuntary leakage of urine. Now with both the male sling and the AUS, it's placed entirely inside the body and undetectable to others, so it's concealed. And I mean, these have like super high satisfaction rates. I find that these are some of the happiest patients in my practice that have had a great outcome from, male sling or an AUS. And I think the reason why it really helps restore normalcy and renew confidence, and it really takes, somebody from a situation where they, really, oftentimes can be suffering from really bad incontinence, and their whole life revolves around the number of pads they're wearing, where the nearest restroom is, what color pants they have to wear, if they're going to leak, the activities that they may or may not avoid because they may leak. And you can go from that to kind of enjoying your life and doing all the activities you want without having to worry about leakage again. I think that's really life-changing for some patients. Okay. Now there are some risks to the procedure, and just like with any surgery. And not all patients are a good candidate for a sling or an artificial urinary sphincter. A lot of times that requires a very thorough discussion with your urologist to determine if you are a good candidate. Some of the risks that can happen with a male sling include device failure, meaning you may still have to wear a pad or two, urinary retention or new urinary symptoms. Sometimes that can be temporary, very rarely permanent. Postoperative pain or discomfort, or sometimes irritation at the wound site or infection. And for an AUS, sometimes you can have device malfunction or failure, which may require a revision surgery, erosion of the urethra and the cuff area, which would require removing the device and ultimately waiting till we can get a new device put back in. Sometimes in the short term after surgery, you can develop urinary retention or sometimes difficulty urinating. And then any infection, pain, or soreness as well. So just to summarize our conversation or talk on stress urinary incontinence. Unfortunately, we do know that it's a known side effect of prostate cancer treatment and several other conditions. But the good news is there's a variety of treatment options. And treatment options can be uncomfortable, but there are great options to hopefully give you a long-term, durable, fantastic result. And a sling or AUS could offer that result for you. And I think it's really important, to talk to your urologist and kind of understand what your options and what would be the best option for you. There are other great resources as well. Um, there's a great website called fixincontinence.com if you want to learn more about this online. And here are some other resources as well. There's a QR code, or you can visit fixincontinence.com/quiz to take a short quiz. And here's another great resource myself. If you have any questions about anything in my talk or anything urologically, this is my office location. This is my office phone number and our website. I'd be more than happy to talk to anybody in consultation and see, what would be, an appropriate option if you're having any issues with male stress urinary incontinence or erectile dysfunction.